penicillins, amoxicillin, ampicillin, cephalosporin, that is 2-beta-lactam group of antibiotics. These are the common. Sulfonamides and beta-lactam antibiotics are the common antibiotics which cause adverse drug reaction. Other antibiotics like fluoroquinolones, ATT, can also cause an adverse drug reaction. And NSAIDs also are the common cause of adverse drug reaction. And the important cause, another important group of drugs that cause drug reaction are anticonvulsants. That is phenobarbital, carbamazepine, phenytoin, and lamotrigine. These are also very important cause of drug reactions. Now the clinical type of drug eruptions. There are various types according to the morphology and severity of the drug reactions. These are urticaria, angioedema, and anaphylaxis 1. Second one is maculopapular or exanthematous drug eruption. Third one, fixed drug eruption. Fourth one, exfoliative dermatitis. Another is DRESS. DRESS, the full form of DRESS is drug rash with eosinophilia and systemic symptoms. DRESS is also called drug hypersensitivity syndrome. Another is SJS, that is Stevens-Johnson syndrome. Another, toxic epidermal necrolysis, and Erythema multiforme. Now the drug-induced urticaria, angioedema, and anaphylaxis. The drug-induced urticaria can be seen in isolation, means only urticaria can be seen, or in urticaria can be seen in association with angioedema and anaphylaxis also. Aspirin and NSAIDs are the most frequently implicated drugs which cause urticaria with or without angioedema and anaphylaxis. And other drugs that causes urticaria are antibiotic, beta-lactam antibiotics, that is penicillins and cephalosporin and NSAIDs. These are the frequent drugs which causes anaphylaxis. And urticaria, angioedema, and anaphylaxis arise within 24 to 36 hours of drug injection. On the first occasion, however, on a re-challenge, the lesions may appear within minutes of drug injection. You can see these are the wheels. Okay? These are all wheels. We have already studied what is wheel in primary and secondary lesions. These are the wheels which are the lesions of urticaria. Now the management of drug-induced urticaria is, first of all, in all the drug-induced adverse drug reaction, we have to first stop the offending drug. It is very important. And according to the severity, we can give either oral or IV antihistaminic. In the oral antihistaminic, the most commonly used oral antihistaminics are, there are two generations of antihistaminic, first generation and second generation. First generation antihistaminics, they are short acting and they cause drowsiness. And second generation antihistaminics they are long acting and the drowsiness is less. So most commonly used antihistaminics these days are second generation antihistaminics. A few examples are levocetirizine, cetirizine, fexofenadine, loratadine, desloratadine. These are the second generation oral antihistaminic that can be used. We can use IV antihistaminics also. Most commonly given IV antihistaminics in case of urticaria, angioedema, or anaphylaxis are Evin. You should give in emergency. And oral and IV corticosteroids. In oral corticosteroid, most commonly we use prednisolone. In IV corticosteroids, the most commonly used drug is hydrocortisone. And in case of anaphylaxis, subcutaneous epinephrine and adrenaline may be required. Second one is exanthematous drug eruption. Exanthematous drug eruption can occur up to 3 weeks after injection of drug, but it usually occurs 1 to 2 weeks after administration. Another one is this urticaria, drug-induced urticaria, angioedema, and anaphylaxis is type 1 reaction, that is IgE mediated, so it is immediately same. And this exanthematous drug eruption is type 4 reaction. So for this, first of all, the body has to develop sensitivity to the hypersensitivity to the drug. It is type 4 reaction, so it usually takes around 1 to 2 weeks after the administration, but it can take up to 3 weeks. It is accompanied by itching, and trunk and extremities are usually involved. Palmar and plantar lesions may also occur. These are the exanthematous or maculopapular drug reaction. Lesions, as you can see, multiple macules and papules, erythematous macules and papules that have coalesced are seen over the trunk area. These are symmetrically distributed. These are extremely itchy. Another one is fixed drug eruption. It is characterized by, it is also type 4 reaction. It is characterized by well-defined lesion which occur at the same time each time the offending drug is taken. Right? It presents 30 minutes to 8 hours after drug exposure. It presents as sharply defined round or oval erythematous plaque, which later becomes dusky, biliceous, and occasionally vesicular or bullous. And the lesions are single or few in number in the first exposure, but if the exposure is recurrent, the number of lesions keep on increasing. And the commonly affected sites are lips, genitals, palms, and soles. You can see these are the lesions of fixed drug eruption. These are oval, hyperpigmented lesion with slight scaling in this case, and this is oval, it's not hyperpigmented actually, it's a dusky red erythematous lesion of the fixed drug eruption. These lesions, after the intake of drug, these lesions appear at the same time if the same drug is taken next time. This is the bullous fixed drug eruption. Right? The lesions of fixed drug eruption are of two types. One is non-bullous and another bullous. In this picture, these are non-bullous fixed drug eruption, and in this picture, this is bullous fixed drug eruption. Now the management, same. First of all, you have to stop the offending drug, and if the lesion is single or few, you can use topical corticosteroid only. But if there are number of multiple lesions, then we sometimes have to use systemic corticosteroid also, like prednisolone. Now this is Erythema multiforme. Erythema multiforme is characterized by target lesions over the extremities. Now you should know what is the target lesion. In target lesion, there are three well-defined zones. As you can see, there is central region of dusky red erythema, central region of dusky red erythema with vesicle also. In this, there is dusky red erythema only, there is vesicle also. It is surrounded by peel area, and it is surrounded by erythematous halo. This is typical target lesion containing three zones. And erythema multiforme is also seen in drug reaction, but it can be seen in other infections also, like herpes simplex virus infection and mycoplasma pneumoniae infection also. Now the severe cutaneous adverse drug reactions. In the severe cutaneous adverse drug reaction, the reactions that are severe are acute generalized exanthematous pustulosis, erythroderma, SCS, that is Stevens-Johnson syndrome, and toxic epidermal necrolysis. Now the AZEP, that is acute generalized exanthematous pustulosis. It is characterized by appearance of seeds of non-follicular sterile pustules, okay, which are localized mainly over the flexus area. And after 2 to 5 days of intake of the drug, these pustules appear. You can see these are all pustules which are non-follicular. It's not around the hair follicles, right? Over the erythematous base, mainly over the flexural area. These are also pustules over the flexural area, and it is accompanied by fever also. AZEP is accompanied by fever also. Now the management, mean management, we have to first of all stop the offending drug, And if the limited areas are involved, we have to apply topical corticosteroid. If there is more extensive involvement, oral corticosteroid has to be given, that is prednisolone. Now, DRESS, drug reaction with eosinophilia and systemic symptoms, or drug hypersensitivity syndrome. It is a multi-system drug hypersensitivity disorder which is characterized by cutaneous features and systemic involvement also. Okay? In hematological involvement, there can be eosinophilia, leukocytosis, lymphopenia, lymphocytosis, thrombocytopenia, and appearance of atypical lymphocytes in peripheral blood smear. Lymphadenopathy is found in more than 75% of the patients. There is generalized lymphadenopathy. And other main systemic feature is also fever. You have to remember fever, lymphadenopathy, eosinophilia plus cutaneous features. In the cutaneous features, there are urticated papular exanthems, which are widespread. It is accompanied by cutaneous edema. Okay? There are multiple morbilliform eruptions and erythroderma may be present. Erythroderma means erythema and scaling involving more than 90% of the body surface area. It is called erythroderma. Sometimes erythema multiforme-like features can also be seen in DHS, that is DHS or DRESS, and head and neck edema is also commonly seen in DRESS. And there can be other system involvement also, like liver, renal, lung involvement also. It is accompanied by fever. You can see there are multiple morbilliform erythematous papules over the trunk. Now the management is, first of all, we have to stop the offending drug and supportive care has to be given. As the generalized body surface area is involved, there can be chances of fluid loss, temperature loss, so we have to give IV fluids and thermoregulation we also have to do. And the mainstay of treatment is corticosteroid therapy. Either corticosteroid therapy is administered topically also, and either orally or IV, depending on severity. Right? In oral, we mostly give prednisolone. In IV, we can give hydrocortisone, we can give dexamethasone. And in some cases, which are refractory to steroid, we have to start steroid sparing agents such as cyclosporine. And for this case of DRESS, the steroid, as we have already discussed, the less severe type of drug reaction like exanthematous drug reaction, drug-induced urticaria, fixed drug eruption, for this, if you start oral steroid, it's only for around 7 days. But for this DRESS syndrome, we have to give steroid for long duration, sometimes up to 2 to 3 months also. Now, drug-induced generalized exfoliative dermatitis. It is also called drug-induced erythroderma. It is defined, erythroderma is defined as erythema and scaling affecting more than 90% of the body surface area. Patients present with generalized scaling erythema associated with pruritus. And there can be constitutional symptoms also like malaise, hypothermia, fever, lymphadenopathy, organomegaly, and high output cardiac failure also. For the management, we have to do identification and withdrawal of the offending drug, which is most important, and we have to start systemic steroid also and give topical emollients. Now, the most important type of severe adverse drug reaction is Stevens-Johnson syndrome and toxic epidermal necrolysis. These two are the severe mucocutaneous reactions, which are characterized by blistering and epithelial sloughing, means separation of epithelium from dermis. And various systemic features also like malaise, fever. And the earliest skin lesions are atypical targets. Typical target lesion means there are 3 well-defined zones, as we have already discussed, and in atypical target lesion, there are No three will define zone, but two, we can see like two zones in the lesion, or purpuric macules, which mainly occur on face, upper torso, and proximal limbs. Mostly the lesions start from face, upper torso, and they spread to involve the rest of the trunk and leg. Sometimes you can see the appearance of targeting lesions over palms and soles also. And the lesions increase in size and number over 5 to 7 days and then coalesce. And the vesicles develop within the lesion. There is positive Minkowski sign also. Minkowski sign means on applying vertical pressure with thumb, there is separation of epidermis from dermis. It is called positive Minkowski sign. It is also seen in immunobullous skin disorders. And due to Minkowski sign, the epidermal detachment produces the area of denuded dermis, right, which bleed and becomes secondarily infected. And there is involvement of mucous membrane also, which is very common. Right? Sometimes the patient in the initial stage of SCS stain, patient may present with only involvement of mucous membrane like conjunctiva, oral mucosa, genital mucosa, nasal mucosa. That is erosive and hemorrhagic mucositis. As you can see, these are the lesions seen in SCS and TN. These are purpuric macules, which in the initial stage, it has just started to become vesicular. Later, you can see these all have become vesicular and bullous. These are the purpuric macules over palms and soles. Over the trunk, and after the rupture of vesicles, you can see it leaves the raw area of the dermis. These are all the raw area of dermis after rupturing of vesicles and bulla. This is an involvement of lips and nasal mucosa. This is involvement of eyes. You can see there is discharge and redness over the conjunctiva. Now, STS and TN is classified according to the severity. STS or Stevens-Johnson syndrome, we call it Stevens-Johnson syndrome if the epidermal detachment is less than 10% of body surface area, plus there are widespread purpuric macules or flat atypical target lesions. It is called overlap of STS or TN if there is 10 to 30% of body surface area involvement. And if there is more than 10% of body surface, more than 30% of body surface area involved, it is called TN. TN is further classified into TN with spots and TN without spots. Okay. TN with spots means detachment of more than 30% body surface area plus widespread purpuric macules or flat atypical targets. In TN without spots, there is no purpuric macules or target lesions. Now the complications, as we have seen, there can be wide areas of denuded area of the skin. There can be fluid depletion, which can lead to acute kidney injury. There can be hypothermia because the main function, one of the most important function of the skin is maintenance of temperature. Due to loss of protein, there can be hypoalbuminemia also, and if there is secondary infection over the denuded skin, there can be septicemia also. These are all acute complications. In the chronic complication, there can be post-inflammatory depigmentation. In the ocular complication, there can be corneal ulcerations, scarring, ectropion, and in case of pulmonary complication, there can be bronchiolitis obliterans. Now, there is one score called Scorton score, which is score of toxic epidermal necrolysis. It is calculated for the prediction of mortality. Okay. There are 7 parameters. First one is age greater than 40 years, presence of malignancy, heart rate more than 120 beats per minute, epidermal detachment more than 10% of body surface area, serum urea more than 10 millimole per liter, serum glucose more than 14 millimole per liter, and bicarbonate level less than 20 millimole per liter. Each of the parameters are given 1 score, right? And if these are the average mean scores, as you can see, if the score is 0, the predicted mortality is 1.2%. If the score is 4, the mortality rises to 62.2%. And if the score is 7, means all these parameters are positive, the mortality is 98.5%. Now the first line of in the management of the SS and 10, first of all we have to withdraw the pulpit drop. Right? And if there is epidermal loss more than 10% body surface area, the patient has to be managed in the specialized unit, either burn unit or ICU. Right? And the supportive care, which is most important, has to be given, like heated environment to prevent hypothermia, fluid replacement, fluid and electrolyte replacement. Okay? For the replacement of fluid, we calculate the body fluid like that of the replacing fluid like that of burn. Right? As you know, there is one formula called Parkland's formula, and the total amount of fluid required is calculated according to that formula, Parkland's formula, and 75% of the fluid that is calculated from Parkland formula is required for the SGS and TM. Right? You must have already studied Parkland formula in surgery also, and we have to give nutritional support also, as there are chances of loss of various nutrients like iron, hemoglobin, protein from the skin. We have to do nutritional replacement also. Most important is protein replacement. We have to give high protein diet to the patient. Right? And analgesia is also very important because there is pain. The reasons are painful. And for the prevention and treatment of infections. If there is already signs of infection, we have to give IV antibiotics. And for the prevention of infection, we have to do regular dressing with a normal saline or potassium permanganate, and we apply Vaseline gauze piece over the denuded area. This is the most important management. And for the definitive treatment, second line treatment, there are 3 modalities: IVIG, systemic corticosteroid, or cyclosporine. Mostly IVIG and cyclosporine we do not use. We mainly give systemic corticosteroid. Either we give oral prednisolone or IV methylprednisolone or hydrocortisone. But the most of the cases, as the drug reaction is severe, we prefer to give IV hydrocortisone. And this IV hydrocortisone is given for 7 to 10 days. Right? Initially, we start with high dose and we rapidly taper over 7 to 10 days to prevent secondary infection, because secondary infection is one of the most common cause of mortality in SCSTM. So, we rapidly taper steroid because the steroid can sometimes cause immunosuppression and the patient is more liable to secondary infection. Okay, thank you. Any questions?